Good afternoon, everybody. I was hoping you weren't laughing at me just saying good afternoon. I'm sure we're going to be dinged by JBA because they're not supposed to have that as our first form. Kathy, please forgive us. It's our sense of humor. Good afternoon, everyone. My name is Alan Chappell, and I'm the Executive Director of the Kaizen Promotion Office, and for the purposes of this afternoon, I'm the team lead of a fantastic team that looked at standardizing admission criteria in the emergency department at the General Hospital for mental health patients being admitted into the inpatient mental health unit at RGH. This is our phenomenal team, each of whom will come to the front and introduce themselves and present their portion of the report out. This is our project form. The title, again, is Standardizing Admission Criteria on the Inpatient Mental Health Unit. Our sponsors, Ram, just keep the form up for a second. Our sponsors are Michael Redenbach and Dr. David McCutcheon, so we want to thank them. And the project form is important because it gives us an organizational mandate to do some work, to do this RPIW. The current state on our project form basically identified a couple things. One, we have two types of patients. One patient is the one that gets admitted, a mental health patient that gets admitted from emergency to the inpatient unit. The second type of patient is the patient that gets discharged from emergency to a community resource outside of the hospital for mental health services. Our hypothesis on the project form is that we felt, our sponsors felt, and they directed us in this regard, was to look to see if there was a population of patients on the inpatient unit that were admitted to the inpatient unit that perhaps could have been treated in community. So that was the hypothesis that we went into, and that was our current state. So this is, as part of an RPIW, we do value stream mapping. This is our current state value stream map, and you'll see the 4 orange boxes that represent a small portion of a large value stream that we focused on. The first box starts with the assessment of the patient in emergency by the emergency psychiatric nurse, and the last box, which shows you the flow of the patient through horizontally the system, is when the patient actually arrives on the inpatient unit. So that is an admitted patient, the one that goes horizontally through the system. Then you see a box at the top, which is the patient who's discharged to community and community resources. Interestingly enough, it's a 50-50 split. Of the patients that come to emergency, 50% get admitted, 50% get discharged. So our future state looks like this. The boxes are exactly the same. However, what we predict in the future, if we're able to adhere to the standard work that we've created in this RPIW, is that the percentages will start to change. So instead of a 50-50 split, what we would expect to see is 75% of our patients discharged to the community and 25% of our patients admitted into the inpatient unit. And the reason for that hypothesis is our PQA data. We did a month audit in our preparation for the RPIW of the number of patients that come through the unit, and you can see the top bar is the total number, or the top line is the total number of patients, and you can see the peaks and troughs. But essentially, on average, every day in emergency, we see about 6 patients. 3 of them get admitted, 3 of them get discharged. So that's the context, the overall context for our work. The next slide in our PQA data represents the results of 2 audits we did, again in preparation for the RPIW. So we went to the 50-bed inpatient mental health unit at the RGH, and we did a spot audit twice of the patients there. And you can see that there's a significant number of patients that are waiting, that are in inpatient beds over 30 days on the inpatient unit. Now that becomes significant in our other PQA data. This is also data from our spot audit. The red portion, 36%, represents patients that perhaps could have been treated in community, but they were on the inpatient unit as admissions. So it is this red portion of the pie that we want to reduce. And that's where we think we've got to start on it with our RPIW. Of that 36% in that red portion of the pie, what was understood was that this is the alternatives to care that they could have gotten in the community. So 36% of those patients, of those, 50% could have gone to a program in day hospital. 10%, I think, could have gone to detox. 12% could have gone to addictions, and so on and so forth. So there were community resources that those 36% could have gone to. The other reason this is important is the cost to the system. For those of us who work in the system, it's a publicly held system, and we are stewards of the system and the resources that we put together, that we put forth. On average, not on average, but looking at medical supplies and looking at staffing costs, $500 per day is spent for a patient on the inpatient unit. And so you can see that if the patient is in long-term care, the cost is lower. If the patient is in addiction detox, it's lower. And in other community resources, it's lower. So if we can get patients to appropriate care in the community, the most important thing is appropriate care in the community, it's also a lower cost to the system. Our target sheet, Dr. Abdullah will talk about the many things that have been accomplished on the target sheet. What I want to point to you is there's 3 things that we focus on was quality defects. We determined a defect to be a patient that was admitted that perhaps could have gotten community resources and been discharged. So that's one. And then the 2 at the bottom are capacity. We wanted to increase the capacity, and we wanted to decrease the cycle time of the emergency psychiatric nurse. Our TAC time was 75 minutes. For those of you in training, TAC time is a measure of demand. So basically, it means that every 75 minutes, we expect a patient to show up in emergency with mental health issues that needs to be seen. And what do we do with that patient? So that became the TAC time that we calculated and we worked with. I'll pass it on to my colleague who will start a chain of events of other colleagues who will talk about the 4 Kaizens we worked on. Dr. O.
Good afternoon all. My name is Dr. Odenebo. I'm actually going to talk on the Kaizen 1, which is to develop the admission criteria. Thank you. So this was done in order to help guide our clinicians in making decisions about disposition. So in order to do this, we did an online survey which helped us to understand the individual admission criteria that is currently in use in the service. So questionnaires were made out and sent to psychiatrists, and we had 11 psychiatrists responded. As you can see on the board here, that risk of harm, either to self or to other people, were the major reasons why patients were admitted to the psychiatric service. Of course, there are other variables as well, which can range from combination of diagnosis, severity of symptoms, level of functioning, social support structure, and behavioral disturbances. So we set to develop a disposition decision checklist. This was based on the result of the survey, as well as the available resources we have in the community and the provisional locus that we have. So we organized a field trial, which took 3 days to do. So, of course, we have examples of the trial we did. So from what we have here, we could see that patients that were admitted had high risk involved, which was not a variance with what we already know in the survey. So but how is this, how has it helped us? When you look at post-Kaizen score, what we did, post-Kaizen score, so it shows that 50% of our patients, post-Kaizen, it shows that 50% of patients that were admitted and 50% were discharged. But this was not a variance significantly with what we already know pre-Kaizen. But what it did show clinically is that all the admissions and community discharges that we did were actually appropriate. So those people that were admitted were meant to be on admission, and those ones that were discharged actually went to appropriate community services that they were meant to go. So what did this tell us? This this is just a way of bringing a common language to admission in the psychiatric service. Of course, this is to serve as a guidance, not by any means intended to replace the individual clinician decision-making capacity. At the same time, we intend to continue to improve on this based on information that is available to us, knowledge that is gradually expanding, and the demography of the Regina region. So thank you.
Good afternoon. My name is Angie Tanyard. I'm a psychiatric nurse from the Regina Mental Health Clinic.
And Maritza Todo, client participant.
We will be speaking to you about our Kaizen number 2, which is to establish a system to connect patients to community services. Once a patient has been seen and assessed by either the emergency psychiatric nurse or the psychiatrist, they may be discharged to the community with recommendations for treatment and a referral to a community agency.
Pre-Psycan were at least 4 business cards that could be given to participants. Post-Psycan, we developed one treatment card. The card having a space to write the treatment plan, resources, and phone numbers. The patient will have this card as a reminder, as well as be able to share this information with the community service, such as the transactional care team and the crisis responsive team.
In addition to the business cards pre-Kaizen, there were several pamphlets that could be given to a patient regarding a community resource. Post-Kaizen, we created a pamphlet that outlines a variety of more commonly used community services that the patient can access depending on their individual need. The pamphlet includes information for resources such as counseling, community health centers, self-help e-therapy, websites with more comprehensive information about community resources, and 24-hour emergency services. This pamphlet also could be utilized in other healthcare sites, such as physician offices. Thank you.
So, hi. Good afternoon. I'm Brenda Mauger. I'm from Sunrise Health Region. I'm in the Lean Leadership Training, and I'm a participant in this RPIW.
And I'm Sharon Clark, also a participant coming from Sunrise Health Region as part of the Lean certification process.
Sharon and I are going to talk about Kaizen number 3, which was to improve the emergency psychiatric nurses' work by reducing waste. Our pre-Kaizen time observation and our standard work combination sheet showed a wait time for the psychiatrist of 75 minutes in the emergency room. The idea we tried was to request the psychiatrist, the on-call psychiatrist, to attend the ER at 9 o'clock in the morning and again at 2 o'clock in the afternoon. We found during the week that that worked very well for both the psychiatrist on call and the psychiatric nurse. For this new process, we created the standard work for the on-call psychiatrist to complete the rounding again at 9 o'clock and 2 o'clock in the afternoon. We did some post-Kaizen time observations, of course, and as you can see on the patient load chart, a reduction of wait time for the psychiatrist to attend the ER from 75 minutes to 15 minutes. So we were pretty excited about that. This idea sheet shows we found that the emergency psychiatric nurse would have to request and then wait for the patient's hospital charts to come up, particularly for patients that came in through the evening and night. So the change we implemented was to have the chart for every psychiatric patient pulled at triage. We had some signage was posted to communicate this new process. And what we found was that this eliminated the EPN's step of requesting the chart herself and thereby allowing her to obtain the chart on a more timely manner.
We had a couple of other projects we worked on through this RPIW, and the first one was identified by an ideal summary sheet, was about the actual drawer space that they had allocated for the EPNs and for psychiatry to access file folders. This shows how the before and the after plan, and you can see visually the before picture there, and then after, that was our goal, to have two roles. I think we have the pictures as well, so you can see it a little bit better. You can see that there was quite a bit of issues there. Okay, and then the after picture is a little more organized, more accessible, clearly labeled. The second idea summary sheet that was generated was in regards to the EPNs not having a designated computer station. As you can see, that would create some difficulties and time lost waiting to get on to check mental health records. So the before Kaizen is that they were running, they're running around. Okay, the next picture should show where that's just a picture of, go to the next picture, yeah. And then this is the ultimate. What we ended up doing was we implemented a cow, and it's all been set up, and it's just for the EPNs, the emergency room psychiatric nurses, which does two things. It makes it more timely for them to do their charting. If the patient isn't in a room accessible, they can go down the hall with it. It's portable as well. It has reduced some of the travel time for them. Okay? Thank you.
Hi there, I'm Jessica Bonish, and I'm a client representative, and I will be presenting our fourth and final Kaizen. For our fourth and final Kaizen, we did the 5S for the emergency psychiatric nurse's office. Pre-Kaizen, it was very messy and disorganized. Things were thrown haphazardly wherever it was most convenient. So we sorted and simplified everything by going through all the materials that were there, all the binders, and deciding what information was necessary and what we were able to get rid of. And then from there, we organized everything that was left over, which is particularly important because there are several EPNs using that office.
Hi, I am Lori Haid, a participant in this RPIW and also the full-time emergency psychiatric nurse. It was my office that we did the 5S in, and to follow up with Jessica, I will briefly touch on standardizing and sustaining the area. Prior to our 5S, our evaluation score was a 1. With the 5S implemented, our score moved to a 3. To standardize our area, we made our pamphlets more visible and easy to find, as before they were mostly in binders and difficult to identify. We have put labels behind them to identify which ones need to be ordered. The confidential recycle bin has been taped off and labeled. To sustain the office, I will monitor weekly the amount of pamphlets and teaching material available and restock as needed. I will also declutter and maintain the office workspace on a weekly basis. I'm very excited for the changes that have happened in Emerge, and I'm looking forward to utilizing them on my day-to-day basis. Thank you.
Hi, I'm Ram Abdullah, physician and sub-team lead. Previously a skeptic physician but for RPIWs, but now physician champion for RPIWs. And next few minutes I'm going to share and celebrate the results of our RPIW. And as seen here in the newspaper, we had numerous initiatives which were all addressed by the end of the week. We also have to make sure that this tempo is maintained by the ones who will be using this, that's the psychiatrists and psychiatric nurses, through multiple skill training checklist. And to share with you the target progress report and results of the sheet, I want to emphasize that by ensuring the use of the checklist to decide on admission of patients from the emergency or not to the psychiatric unit, it was found that the defect rate was brought down to 0 from pre-Kaizen of 44%. So that was quite a promising initial improvement of quality initiative. Now in summary, besides all the Kaizen you heard about, we also ensured that there was a portable cow computer for the psychiatric nurse in order to improve her time management. As well as we also put into place the automatic flagging of all charts to be brought into the emergency for the psychiatric patients so that there's no delay. And last, I'd like to thank everyone who gave us their advice and support. And that's the list. That's the list which, on behalf of our team, I'd like to thank them. Thanks.